Hello and thank you for joining this OncLive peer exchange. Serous advanced ovarian cancers of the ovary, fallopian tube, and peritoneum remain clinically challenging with high mortality rates, particularly in this setting of advanced disease. Although many of these cancers respond well to initial cytoreduction and chemotherapy, the vast majority will unfortunately recur and die. Therefore, it is paramount to understand optimal management of this disease and how to achieve the best outcomes for each individual patient in a personalized fashion. In this OncLive peer exchange panel discussion, my colleagues and I will discuss the latest research surrounding the treatment of advanced ovarian cancer and hopefully provide practical information on how to apply the latest findings into your clinical practice. My name is Brad Monk. I'm a professor of gynecologic oncology at both the University of Arizona and Creighton Universities, again in Phoenix, Arizona. I'm also part of the Arizona Oncology practice, which is part of the U.S. Oncology Network. Participating with me today are my very good friends and colleagues. I'd like to introduce to you first Ursula Matulonis, who is Director and Program Leader of Gynecologic Oncology at the Dana-Farber Cancer Institute. And then David O'Malley, Professor of Gynecologic Oncology in the Department of Obstetrics and Gynecology at The Ohio State University. And Matt Powell, Director of Gynecologic Oncology at Washington University in St. Louis. Shannon Weston, Associate Professor and Director of Early Drug Development at MD Anderson in Houston, Texas. Thank you for being with us.
Thanks for having me.
All right, well, let's get started. I think we understand the unmet need. I think we understand that there are two components, surgery and chemotherapy. So Matt, what's the role of surgery in ovarian cancer, newly diagnosed ovarian cancer?
Well, Brad, I know you initially set this up with advanced cases, but we also want to identify those patients that present with early stage disease. And so again, referral to a high volume provider that takes care of these patients, most notably a gynecologic oncologist, I think is paramount. Allows us to do appropriate surgery, identifying those patients that have early stage disease, perhaps low-grade tumors, that allows us to avoid chemotherapy when these patients are fully staged. And we mean fully staging, they're having an omentectomy, they're having lymph nodes done. We know that's not happening widely across communities. We think that's very important to not only help identify those that benefit from more aggressive therapies, but also holding back and treating appropriately when patients don't need it.
Right, so that's great. Not every patient needs chemotherapy, particularly those early stage adequately operated on patients. But debulking is another opportunity, and recently ASCO and the Society of Gynecologic Oncology has released a statement about frontline debulking. What do you think?
You know, we really need to look at this very closely, that each of these patients, particularly in all ovarian cancer, but when you have advanced stage patients, they need to be assessed by a GYN oncologist. And that's the decision on chemotherapy or surgery first. But even if they have chemotherapy, they're ultimately going to have surgery. Many patients can have primary surgery, and the goal of this primary surgery is to remove all disease, a complete cytoreduction for these patients. If we make the decision based on the assessment prior to the surgery, either on their performance status or the distribution of disease or other factors, for chemotherapy, 3 cycles, then interval debulking with a goal of, once again, removing all the disease, and 3 additional chemotherapy cycles afterwards. And again, this is very important. There's ASCO and SGO combined statement.
So got to see a gyn-onc before you start neoadjuvant.
Correct.
Yeah, that's important.
Absolutely.
Okay, how often do you think we use neoadjuvant, Ursula? Is that common or uncommon, or does basically every patient start with an upfront debulking?
So I think I know we've discussed the importance of the patient being seen by a gynecologic oncology surgeon, and I do think that the rate and the usage of neoadjuvant chemotherapy, I said intraperitoneal, but neoadjuvant chemotherapy is increasing with the realization that there are now several trials when the patient's been assessed by a gynecologic oncology surgeon, patient's not deemed to be an operative candidate up front, that neoadjuvant chemotherapy renders a very similar progression-free survival and overall survival result, and it's safer. It improves patient outcome. It reduces your surgical complication rate, hospital stays, et cetera.
It's really been one of the breakthroughs that chemotherapy can convert an inoperable patient to an operable patient. And it's certainly changed my practice, I would say, in almost half the cases.
Yeah.